Hello doctors, this is Dr. Hira Salman. So today we are going to discuss about this one of the important topic for exam point of view, that is gastroesophageal reflux disorder. So let's just start it. Alright, so starting with the definition, it's a condition which results due to reflux of gastric content and leads to initiating symptoms and complications. So whatever the content which is coming from the stomach into the esophagus that actually produces symptoms and complications, that condition is gastroesophageal reflux disorder. So what are the most important causes? So first thing, we should know what is the most common cause, and other than we should know what are the other causes. But the most common cause is inappropriate relaxation of lower esophageal sphincter. This lower esophageal sphincter is actually not a true anatomical sphincter. It's not a true anatomical structure. It is created by the different response of the smooth muscle cells. Actually, it actually composed of smooth muscle cells. So because of the contraction of the smooth muscle cell, this stricture is going to be produced. So definitely it's created by different response of the smooth muscle cells in the distal esophagus. So there are many factors which are going to affect on this. Like they can decrease the tone or losing of the sphincter. That can only be happen when the patient is using nicotine or the patient is consuming alcohol, must be taking caffeine, peppermint, chocolate, calcium channel blockers that's going to relax the muscle, nitrate as a vasodilator. So these are all the things which are going to affect on the smooth muscle cells, and definitely they are going to produce effect on this sphincter, which is actually not a proper anatomical structure. It's just a muscles, a combination of muscles which are responsible, and they are producing, because of the contraction, they are just acting like a sphincter. Then we have obesity. Obesity is also one of the common causes of GERD. So what is the main pathophysiology behind obesity? If someone is obese, then how the GERD is related to that patient? Pathophysiology in obesity includes esophageal motor disorder. So this is all because of the motor disorder. This lower esophageal sphincter abnormalities, a trend toward development of hiatal hernia. But please make a point here that hiatal hernia itself is not a cause of GERD, but actually hiatal hernia is going to worsen the cause, worsen this particular condition. Someone is having someone is having this gastroesophageal reflux disorder already suffering, and because of having hiatal hernia, it will be multiplied. So, and increase intragastric pressure. Any factor that is going to increase the intragastric pressure, definitely it will lead to this GERD, and obesity is one of the most important thing in that. And increased gastric capacity, like in obese patient, the capacity is increased. So that's why it is going to affect on GERD. So this is how obesity is related to GERD. Then we have some acid hypersecretion. Acid hypersecretion, how in a case of like Zollinger-Ellison syndrome. So in this syndrome, there is acid hypersecretion, and because of the hypersecretion of acid, patient must be experiencing this GERD. Then hiatal hernia can only worsen reflux. It is found in 1/4 of patients with, see, this is the point which I have just told you earlier, that hiatal hernia itself is not a cause. Hiatal hernia can only worsen reflux. It is found in 1/4 of patients with non-erosive GERD and 3/4 of patients with severe erosive esophagitis, and over 90% of patients with Barrett esophagus. So those who are having Barrett esophagus, those who are having this non-erosive GERD, those who are having this erosive esophagitis, mostly these patients have this hiatal hernia, and if the hiatal hernia is there, they're definitely going to worsen the condition. Anticholinergic medications, use of anticholinergic medication, Sjogren's syndrome, and oral radiation therapy may exacerbate GERD due to impaired salivation, because anticholinergics, they are just going to decrease the production of saliva. Sjogren's syndrome, no tears, no saliva. Oral radiation therapy, definitely there will be decreased salivation. So these are all the things, because of the decreased salivation, definitely the patient is going to experience this GERD symptoms. Now, to summarize broadly, we can say pathophysiology of GERD mainly include. So, what are the key points which we need to focus more on pathophysiology? There must be dysfunction of gastroesophageal junction. Whatever the thing, whatever the cause that is actually going to disturb this function of gastroesophageal junction, and that is the first and foremost etiology of this GERD. Then we have some irritant effects of refluxate. Whatever the refluxate is coming, whatever the gastric content is coming from stomach into the esophagus, back to the esophagus, they are going to produce some irritant effects, and that will lead to GERD symptoms or maybe their complications. Then abnormally esophageal clearance and delayed emptying. So these are all the factors which are especially broadly in terms we can say they are included in the pathophysiology of GERD. Alright, so what clinical findings, what signs and symptoms you are going to observe in your patient? Most common is epigastric pain, burning pain. The patient must be complaining of this epigastric burning pain. That's your first symptom and most common. Remember, for exam point of view, we should know the most common things. Heartburn is also called pyrosis. So, sign and symptoms, we can divide sign and symptoms broadly into two categories: related to the esophagus and which is not related to the esophagus. So, esophageal symptoms and non-esophageal symptoms. In esophageal symptoms, again we have typical and atypical, and non-esophageal we have respiratory and non-respiratory. We are going to deal with them in detail. So see here we can say these are the typical symptoms and atypical symptoms, which is actually the esophageal symptoms. Here you can say, so these two upper two, 1/4, this half portion is at 1/4, half portion is for esophageal one, and the lower one is for non-esophageal one. So esophageal we have this atypical and typical. So what are the symptoms if the patient is having atypical esophageal symptoms? So there must be a chest pain, dysphagia, odynophagia, difficulty plus pain during swallowing, that is odynophagia. So if the patient is complaining of chest pain, if the patient is complaining of dysphagia, difficulty in swallowing, difficulty plus pain in swallowing, so that are actually atypical symptoms of GERD that comes under the heading of esophageal, right? And typical symptoms include heartburning, acid regurgitation. These are the typical symptoms of esophageal symptoms especially. Then we have non-esophageal, right? Non-esophageal, we have respiratory and non-respiratory. So there we can see respiratory, non-respiratory. So these lower two are actually non-esophageal. In respiratory, we have asthma, we have chronic laryngitis, wheezing, chronic cough, aspiration pneumonia. These are all the things, the patient must be having, and they are producing these symptoms, which actually we are considering them. If the patient is having asthma, if the patient, of course asthma is not a symptom itself, but wheezing if you're going to hurt, and if you can see some inflammation or cough is there, chronic cough is there, then you might say these are the respiratory symptoms of non-esophageal. Broadly we can say non-esophageal symptoms. Now, non-respiratory symptoms, sore throat, hoarseness, dental erosion. So these are also, the patient must be complaining of this, and actually the patient is having GERD, if the patient is having dental erosion, if the patient is presenting with hoarseness of voice or sore throat is there, might be a case of this gastroesophageal reflux disorder. We have to rule out it. Now, investigations. What are the investigations we are going to perform? Clinical diagnosis is sufficient. Clinically, we have to see our patient. But if you're talking about the most accurate one, because for theory purpose, we should know what is the most accurate diagnostic test. So the most accurate diagnostic test is 24 hours pH monitoring. We can just monitor the pH via 24-hour collection, watching. So this is the most accurate one. Then simultaneously, we have to initiate proton pump inhibitors. Initiate PPI if no improvement, then increases the doses of PPI 2 times daily for 4 to 8 weeks. So first of all, you are going to start PPI, then you will see if there is no response, then you are going to double the PPI dose, like we are going to giving it 2 times daily now for 4 to 8 weeks approximately. If after providing this PPI twice daily, after 8 weeks, if still your patient is not getting better, it means that now he is an ideal candidate for endoscopy. We'll go for the endoscopy then. And esophageal manometry, which is actually called a study of esophageal motility, that we can also perform. So these are the points which we have to consider. First of all, clinically we have to diagnose. Other than that, for most accurate diagnostic purpose, we'll go for the 24-hour pH monitoring. We will start the PPI therapy. No response, we'll just double the dose of PPI. Now 2 times daily, starting with the first 1 time, and then we'll increase the dose to the 2 times, right? And then up to 8 weeks. Still no improvement, go for endoscopy or esophageal manometry. Now, how we are going to say, like when we are performing this endoscopy, what are the points which we must consider? If endoscopy shows esophagitis, this is, sorry, by mistake, is esophagitis, H is missing here. So if endoscopy shows esophagitis, so now this is clear cut, right? No need for further testing, just go for the treatment option. But if endoscopy is normal, then we will proceed to 24-hour pH monitoring, which is the most accurate test. Remember, the most accurate one is 24-hour pH monitoring. So first, if endoscopy is showing esophagitis, then it's clear cut. We have to start with the treatment, right? But if endoscopy is normal, then we will proceed to 24-hour pH monitoring. If results are consistent with good, then we will proceed to the surgical option. And surgical option, we have this Nissen fundoplication. Now, what are the absolute indications of endoscopy? In which condition a patient must undergo endoscopy? That is heartburn accompanied by red flags. Later we will see what are the red flags. But better I should show you first red flags. So these are all the red flags. If the patient is having weight loss, the patient is having difficulty in swallowing, if the patient is having continuously persistent vomiting, if the patient is having family history of GI cancer, or if there is any bleeding history. So these are all the symptoms which are considered to be red flags symptoms. And if the patient having these red flag symptoms, he's an ideal candidate for endoscopy. Now coming back towards the endoscopy indication, absolute indications. First of all, this heartburning, which is accompanied by red flag symptoms. Then persistent reflux symptoms after therapeutic trial of 4 to 8 weeks of PPI 2 times daily. We have already started this PPI and increased the dose to 2 times till 8 weeks. There's still no improvement in patient symptoms. We'll proceed to endoscopy. History suggests dysphagia, continuous dysphagia. Go for endoscopy. High risk for Barrett esophagus, that's very important. Long-standing GERD, untreated GERD will lead to Barrett esophagus. After 10 years, that this Barrett esophagus is going to convert into adenocarcinoma. So we cannot just leave like this. We cannot leave Barrett esophagus like this. We have to treat. And not Barrett esophagus, we have to treat this GERD in order to prevent your patient getting into Barrett esophagus and adenocarcinoma later on. So, high risk for Barrett esophagus, which patients are at high risk? If the patient is male, he is having age more than 50 years, he is obese, he is white, he is on tobacco, he is having long history of all these symptoms, right? Or especially this GERD symptoms. So these are the patients which are actually high risk of having this Barrett esophagus later in their life. So you will go for endoscopy for these patients as soon as possible. Red flags, we already covered this. Now repeat endoscopy. Okay, done. We are just done with the endoscopy. Now when do we repeat? Repeat endoscopy after 6 to 8 weeks of PPI therapy. We have already given PPI for 6 to 8 weeks. And now you are going to repeat endoscopy. In case of the severe esophagitis, because it can mask Barrett esophagus or symptoms. That's very important. Repeat endoscopy after 6 to 8 weeks of PPI therapy in case of severe esophagitis. Because once the patient is having severe esophagitis, there may be a chances that there is underlying Barrett esophagus, but we can miss that at that time. So after giving PPI, better again go for endoscopy just to rule out Barrett esophagus, because previously, because of severe esophagitis, the symptoms of Barrett esophagus may be masked. So in order to reveal those symptoms after PPI, approximately 8 weeks later, we can just repeat endoscopy to make sure there is nothing related like Barrett esophagus. Now, indications of esophageal manometry. When we are going to perform manometry, this is after endoscopy, right? So, manometry means that study of esophageal motility. Patients who have a normal gastroscopy but with chest pain or dysphagia. Gastroscopy is normal, but the patient is having chest pain or patient is having dysphagia, better go for manometry. It is done to diagnose abnormal peristalsis. So this is actually a test for abnormal detection of abnormal peristalsis or decreased lower esophageal sphincter tone but cannot detect the presence of reflux. Reflux thing that cannot be detected with the help of this manometry. Only you can just observe the peristalsis and you can just see, this decreased lower esophageal tone. Mainly used to rule out scleroderma and achalasia. So this manometry actually we are usually performing for the patients, those who are having scleroderma and those who are having achalasia. It's not an ideal testing for GERD. For GERD, the ideal testing is 24 hours pH monitoring. That's important to remember. Okay, so what are the differential diagnoses? DD is angina pectoris. It's a differential diagnosis. The one who is having eosinophilic esophagitis, that's a differential diagnosis. Esophageal motility disorder like the scleroderma and achalasia, that we can differentiate on the basis of manometry, right? And there are other certain specific symptoms as well, right? As far as achalasia is concerned. Peptic ulcer, reflux erosive esophagitis may be confused with pill-induced damage or eosinophilic esophagitis or infection like cytomegalovirus infection, herpes candida. So these are the options where we have to make a differential diagnosis, and then we'll come to the final diagnosis after endoscopy and after 24-hour pH monitoring if it's really indicated. Now, what are the treatment options? Whatever treatment you are going to give, your main goal will be either we are going to treat symptomatically our patient, just we want to heal this esophagitis, or we just want to prevent our patients getting into complications. So, your goal will be symptomatic treatment and prevent complications. So, if you're considering mild intermittent symptoms of GERD, first of all, we advise our patient for lifestyle modification. We advise to, go for exercise, just weight loss. Weight loss you're going to prescribe. And if the patient is having symptoms, particularly at night, like the patient is having nocturnal symptoms, you will ask your patient to elevate the head of the bed on 6-inch block, at least 6-inch high, or foam wedge to reduce reflux, and it also helps increase esophageal clearance. So just ask your patient to lift his head at least 6 inch above, so that it helps increase esophageal clearance. Then cut down citrus, tomatoes, coffee, spicy foods. So some dietary modifications as well. 5. Spicy foods, citrus foods that precipitate reflux like fatty food, chocolate, peppermint, alcohol, cigarette. These are all the products which we ask your patient to avoid. So, right? These are all for, especially for mild intermittent symptoms. Patients should be avoid lying down within 3 hours after meal. So it's always better to lie down after 3 hours, not within 3 hours. Patient with infrequent heartburn should revise antacid or oral H2 receptor antagonists. Those who are having infrequent heartburns, they should change their antacids, right, or H2 receptor antagonist. Duration of action of antacid is less than 2 hours. That's an important point to remember here. Now, what are the troublesome symptoms? For the troublesome symptoms, what is your initial therapy? Those who have known complications, troublesome symptoms like complications are there. Because of GERD, long-standing GERD, complications are there, and how you're going to treat your patient. So first, initial therapy. Those who have known complications of GERD, like erosive esophagitis is there, Barrett's esophagus is there, stricture is there, then what you're going to do? Once daily oral PPI, 30 minutes before breakfast for 4 to 8 weeks. So starting with once daily. But if symptoms are not relieved, then you can shift your method, not exactly shift, you can just increase the dose to 2 times daily for approximately again 4 to 8 weeks, and always advise your patient to take these PPIs daily 30 minutes before meal. It's mandatory to advise our patient to take it before 30 minutes before meal. That's an important point. Now for the long-term therapy. Of course, long-term therapy, patient who require twice daily proton pump inhibitor therapy should be maintained on long-term therapy with 1 or twice daily. You will ask your patient to just keep taking these medications. Extraesophageal reflux manifestation. If there are any extraesophageal manifestation, how you are going to treat them? Say for example, we'll go for their esophageal impedance pH testing, or oropharyngeal pH testing may be performed in patient with extraesophageal symptoms. Persist after 3 months of PPI therapies. 3 months continuously the patient is on PPI. Again, that patient is having some symptoms. We can go for oropharyngeal pH testing, or we can go for this, especially for esophageal impedance pH testing. Unresponsive disease. For unresponsive patients, which are about 5% patients are unresponsive. They never get improved. These patients should undergo endoscopy for detection of severe, inadequately treated reflux esophagitis and for other gastroesophageal lesions that may mimic GERD. So we just want to go with these patients, those who are unresponsive, especially for endoscopy. Now we have surgical treatment also. Surgical treatment afford good to excellent relief of symptoms. We just want to get rid of symptoms. We want for 100% relief symptoms, we'll go for surgical option, the surgical fundoplication. And healing of esophagitis in our 85% of properly selected patient, it is performed by laparoscopically. So it's a good option. Laparoscopically, we can just do this Nissen fundoplication or surgical fundoplication. Now, of course, complications, anything has complications, everything has complications. So here also we do have complications. The patient might develop esophageal stricture or inflammation of esophagus is there, ulcer is there, bleeding may be there, barrel esophagus, long-standing GERD, untreated GERD lead to barrel esophagus lead to adenocarcinoma, right? Then when to refer? As GP, at what point I'm going to refer my patient? Typical GERD, do not respond with twice daily PPI. First, you're putting your patient on 1 daily dose of PPI till 8 weeks. Still, your patient is not responding. Symptoms are there, GERD symptoms are there. You will ask your patient to take it twice daily for 8 weeks. Still, symptoms are there. Then you will refer your patient to gastroenterologist, of course. Patient with suspected extraesophageal GERD symptoms. If there is any extraesophageal GERD symptoms that do not resolve with 3 months of twice daily PPI, 3 months you're asking your patient to take PPI twice daily, but still he's having extraesophageal symptoms, you will ask your patient to book an appointment for gastroenterologist. Patient with significant dysphagia or other alarm symptoms for upper endoscopy. So if there is an alarm symptom, if there is any red flags, you will ask your patient for endoscopy, and definitely for that you have to refer your patient to gastroenterologist. Those patients who are having barren esophagus, definitely are not going to see those patients, we will refer them. And surgical fundoplication. If surgery is needed, we'll ask the patient to go for gastroenterology review. Alright, so this is all about GERD. See you next time.